Okay, good morning, friends. Welcome back to Saturday Club of Vadodara meeting. Today we have Dr. Rumin Sa, who actually doesn't require any introduction. He has been a very regular speaker at Saturday Club of Baroda since many years, I would say. But anyway, he is a very eminent consultant, senior physician practicing in Vadodara. And his areas of special interest are diabetes, non-invasive cardiology, hypertension, dyslipidemia, obesity. And in most of these topics we have heard about. He is involved as a faculty and organization of academic programs in various associations like IMA, API, etc. And of course, he is a very popular speaker at various academic fora. And he has other sides to his personality. Also, he's an avid reader, and we have had the opportunity to listen to his book reviews in the past. And he's also a marathon runner and a very close friend of mine. So, Rumin, thank you for agreeing to be with us once again. And today he's going to talk about obesity, changing landscape of therapy. So over to you, Dr. Rumin. You can start your talk. You can speak for about 40-45 minutes, and then we'll have discussion for 10-15 minutes. So over to you, Dr. Rumin.
Morning, Satish, and good morning, friends, senior colleagues. It's a pleasure and privilege to be talking on a very exciting upcoming topic, obesity, the changing landscape of the therapy. I apologize, there is some problem because which my face does not come on the screen, but that's okay. The other device, if I start, there is an echo. So I'll go ahead with this. The topic is obesity, changing landscape of the therapy. Now, well, I would try to discuss recent advances in obesity, the drug therapy of obesity, and exciting recent drug trials. The time limit would not permit me to discuss about the nuances of diet, bariatric surgery, and BMI controversy in obesity. So, this is going to be the flow of talk. Well, this is a gentleman, 44-year-old male. And if you see here, this was his 36th visit on 12th July 2024. It was 36th time that he had come to show me. He's a 44-year-old male having hypothyroidism, diabetes. His height is 170 centimeter. His weight is 185 kilo. The BMI is 64. It's a morbid, severe obesity. And he was admitted in past frequently for recurrent skin and soft tissue infection. But this time he came with a significant urinary tract infection in July 24. On investigation, he was found to have a staghorn calculus. Was referred for PCNL surgery at a tertiary care hospital. The logistics of taking him on an OT table, the logistics of getting his venous access, the anesthesia was so difficult. The surgery almost lasted 6 to 8 hours. 3 drains were put. The planning of surgery, the execution and outcome were sort of very, very challenging for the whole team in tertiary care hospital. So this is just one aspect of difficulty in managing a morbidly obese patient. And we all see such patients day in, day out. So till 2021 June, the management of obesity was a dull field with very poor returns and was a sort of a nihilistic point of view. That means you go on treating the patient without expecting much results. In December 27, Ozempic, semaglutide, was introduced or approved by US FDA for management of diabetes. And it was in June 21 that the same drug was approved by US FDA for management of obesity. And it was this introduction or approval of semaglutide in management of diabetes mellitus that was a tipping point. That was a paradigm changing point in management of obesity all over the world. Soon after the introduction, the company made it a publicity sort of they published or they printed and they kept it all over media, in newspaper, in TV, at stations, the drug Wegovy as a drug for reduction of weight. And what happened? If you could see, this was the advertisement which was in every possible medium that you could think of. Soon after, the drug changed and became the top drug all over world. Not only did it become the number one drug, it changed the fortune of the company. And no doubt this company which marketed it became number one company in Europe, beating the major other companies as far as financial net worth was concerned. And therefore, the drug became the most valuable company and made the company most valuable, beating LVMH and many other companies, showing that the drug changed the management of the obesity and became a super bumper success. In fact, the drug was not available, and therefore it was very difficult to get hold of the drug to a genuinely deserving patient. So this was the drug which changed the outcome and management of obesity. Anyway, obesity has so far been considered as a white disease, a disease of Caucasians, a disease of Western world. And you could see so many cover stories which have come in time showing obesity as a culprit. And then there were two very nice issues of economists on obesity. Come to India, and it was believed that we are in a new age of obesity. How did it happen? There were reviews and there were articles in lay press about the increasing incidence of obesity. But India is not behind. This data shows that 1 in 5 in India is obese or overweight. So, as bad as the world has, India also has a high number of obese patients. And if you see, India today long back gave these two cover stories: Girth of a Nation on obesity, unhealthy teens, obesity in teens, and recently a very interesting cover story on the new drug that we discussed, semaglutide, how it has changed the dynamics. The overall prevalence of obesity in India is 5.21%, very high in Punjab and Tamil Nadu, but in Gujarat it is close to 5.6%, and overall prevalence is 5.21%. If you look over a period of time from 2020 to 2035, there is going to be an increase in incidence of obesity as we go from 2025 to 2030 and 2035. So if you look at this data, almost 73% of urban Indians are overweight. Almost half of urban Indians are obese, and the maximum risk age is between 28 to 38 years. And average person goes from healthy at 26 to obese at 38 years in India. If you look projection of obesity prevalence in India by 2040, we are going to have a huge number of patients of obesity in rural area, in urban area, and overall national prevalence of obesity is going to increase. Well, obesity in India is because of various reasons: the genetics, the ethnicity. We have so-called Y discrepancy, or thin, low BMI sometimes in some patients, but a large number of patients now, because of our past history, are getting huge accumulation of fat because of low caloric expenditure. Then there are reasons like change in diet and lack of physical activity because of rapid urbanization, environmental pollution, and this has led to higher incidence of obesity in India. Obesity itself requires a very scientific approach, and the most important parameter to classify obesity so far has been BMI. And in Asians, Southeast Asian, the cutoff of BMI is 18.5 to 22.9. A person between BMI of 23 to 25 is overweight, and persons having BMI about 25 are obese. And then if the obesity person has obesity or BMI above 30 is obesity grade 2, and between 35 and 40 is grade 3, and so on. This BMI cutoff is different in Asians as compared to Caucasian, meaning thereby that even at a BMI of 23, which otherwise is a healthy BMI for Western population, we Indians or Southeast Asian are vulnerable to problems of obesity. So, because BMI is an old tool, there have been new diagnostic criteria, and Sharma in 2009 from Edmonton proposed this clinical staging system for obesity, one step ahead of BMI. Here, there are stage 0 to stage 4 of obesity, depending on the functional ability, the mental ability, and other risk factors. So, for example, if a person had completely normal BMI, he would go into stage 0, but with some restriction in functional capacity and obesity-related comorbidities and the other end organ diseases. Patients were labeled as stage 0, stage 1, stage 2, stage 4, showing that as your stage goes up, mind you, BMI classifies patients according in grade 1, BMI classifies patients into grade 1, grade 2, grade 3, and Edmonton obesity staging, OSS, instead of that, measures major parameters, and this is going to be a staging system for a lot of patients that we are likely to see in future. And depending on that, we decide the line of treatment. So how do you diagnose a patient of obesity? Well, you have body mass index, you have waist circumference, waist hip ratio, and skin fold thickness. But the criterion or the major decision-making factor is BMI. Then you have DEXA and MRI to find out fat in the body for exact confirmation of fat in body and the staging of obesity. Obesity itself leads to multiple problems. We have high incidence of hypertension, heart failure, vascular diseases, atrial fibrillation. You have high chances of getting osteoarthritis, back pain, multiple urinary infections. Malignancy like colon, breast, and pancreas are known to occur in obese patients. Then you have a lot of metabolic disorders like diabetes, fatty liver, dyslipidemia, cholelithiasis, gout, sleep apnea, asthma, COPD, male infertility. These are also concomitant factors which do exist in patients of obesity. Well, obesity itself leads to a lot of stress, leading to anxiety, panic disorders, and depression. So obesity itself is a pivot from which a lot of other diseases can go ahead. So if you look at obesity, the whole fulcrum of obesity, you have mechanical complications like arthritis, reflux, respiratory failure, and obstructive sleep apnea. You have metabolic complications like infertility, cardiovascular disease, gout, hypertension, diabetes, non-alcoholic fatty liver, dyslipidemia, and you have behavioral and mental health complications like depression and anxiety. Attached to it is stigma or discrimination that an obese person is likely to get. And therefore, the onus is on us to treat such patients aggressively, because even 5% weight reduction, just 5% weight reduction, can very well show remarkable improvement in blood pressure, dyslipidemia, dysglycemia, cardiovascular disease, prevention of diabetes, arthritis, sleep apnea, and non-alcoholic fatty liver, and so on. So even a 5% weight loss, which is feasible in a lot of patients, can lead to so much of improvement in quality of life. If you look at the relation of reduction in obesity with disease prevention, a 10% reduction in weight can totally prevent onset of diabetes. A 20% reduction can lead to remarkable improvement in hypertension. A 25% reduction in weight can lead to remission of type 2 diabetes and remission of non-alcoholic steatohepatitis, showing that taking care of obesity with whatever we have is going to be a great help in cutting down disease burden, both metabolic and biomechanical in large number of patients. And therefore, it is important to reduce weight as fast as. Now, can we offer lifestyle modification and keep quiet? If you look at various trials, diabetes prevention program, Finnish study, look ahead, direct and RAP, despite a period of 5 to 9 years, there was a weight loss, which was roughly between 7 to 9% in some patients. But this weight loss was transient, could not be sustained, and required a lot of persuasion and willpower, both on the part of physician and on the part of the patient. Therefore, lifestyle modification in obesity certainly plays a major role, but requires sustained efforts and requires a lot of perseverance. And therefore, it is important to look at therapy in management of obesity. Now, if you look at, these are various timeline of introduction of anti-obesity medication. Right from 1933, when Stanford University introduced DNP for management of hypoglycemia, for management of obesity, there have been various drugs in 1947, 56, 59, up to 2021, which were introduced for management of obesity. They came into market. Some of them were withdrawn because of side effects. Some of them did not succeed because of the very poor cost-benefit ratio. If you look at USDA approval, right in 1997, sibutramine was in 1970s. It was fenfluramine and dexfenfluramine, which led to a lot of valvular disease and therefore was taken out of market. It was 1999 when Orlistat came into market that there was some sort of ray of hope that the drug is going to work, and then came lorcaserin. But none of the drugs did give good results, and therefore there was a dire need of a good drug to treat obesity. So the first generation of obesity medications that we used to use before 2021 were phentermine, bupropion, naltrexone, topiramate, liraglutide, and metformin. But there was a huge gap in the effects of these drugs. If you look at these drugs, the change in body weight used to be between almost 4 kilogram to 11 kilo over a period of 1 year, sometimes over a period of 2 to 3 years. There were some benefits in systolic and diastolic blood pressure, but most of the effects were transient, suboptimal, and there were lots of side effects of first generation anti-obesity medications, showing the need of a second generation drug. And then, what is a second generation obesity medication? This second generation medication has ability to safely produce an average of more than 10% placebo-subtracted weight loss. That means the weight loss is more than 10% as compared to placebo in randomized clinical trials. This is over that attributable to significant dietary change and significant exercise in majority of patients, or ability to safely produce more than 15% weight loss in over half the patient as an adjunct to lifestyle. So a drug to be successful or to be labeled as a good second generation obesity medication has to have more than 10 to 15% weight loss comparable or better than placebo. And therefore, if you look at drugs, the recent generation drugs, so the first generation drugs usually stop at weight loss between 5 to 7%. It is the second generation drug, mainly semaglutide, which changed the outcome, and we see now very good results of weight reduction. So now, which are these second generation drugs? So the first drug that has been used and become a bumper success is something known as incretin. Now, what is incretin? Incretin is a gut hormone which, under physiological circumstances, stimulates secretion of pancreatic hormones, that is insulin, glucagon, pancreatic polypeptide, and pancreatic somatostatin. So these are the drugs which are incretins, which are used in manage or GLP-1 analog and DPP-4 inhibitors are major incretins which are available all over the world. Quincritin is a drug that activates both GIP and GLP. So far the drugs that we used to use, for example, liraglutide or drugs like DPP-4 inhibitors, were working only on glucagon-like peptide 1. Now we have drugs which work on both GLP-1 and GIP, showing better effects. And then you have triple receptor agonists, which work not only on GLP, GIP, but also work on glucagon. So let's see those drugs. So the first drug that we think we need to discuss is semaglutide. It is a GLP-1 analog. That means it behaves and works like GLP. What are the beneficial effects of GLP? On brain, it improves satiety and reduces appetite, improves energy expenditure. In liver, it reduces glucose production and hepatic fat. In pancreas, GLP causes increase in insulin secretion, decrease in glucagon secretion, and somatostatin secretion. There is increase in lipogenesis and reduction in inflammation in adipose tissue. There is improvement in glycogen synthesis in skeletal muscles, and there is natriuresis, reduction in oxidative stress as far as GLP action on kidneys is concerned. Systematically, because of these various effects of GLP-1 analogs on brain, liver, pancreas, adipose tissue, and heart and vasculation, there is reduction in body weight, there is remarkable improvement in glycemic control and reduction in inflammation. If you look at semaglutide, it is a glucagon-like peptide. It works on endocrine L cells, and there are minor effects on pancreatic alpha cells. Basically, as we discussed, it works on hypothalamus, pancreatic beta cells, heart, lung, improves satiety, reduces gastric emptying, reduces gastric motility, and improves postprandial secretion. And therefore, the drug is used primarily for management of diabetes because of its various action on pancreas, liver, stomach that we discussed. This is the drug which has been used extensively in management of diabetes. In fact, 2017, it was approved in management of diabetes. And if you look at various trials of semaglutide in diabetes, pioneer trials were done. Each trial showed that the drug was an effective anti-diabetic drug. So basically a drug which was used purely for management of diabetes and showed great results in various trials across the world with reduction in sugar to the tune of as high as 2.4, 1.5 to 2.4 reduction in A1C. The drug then was found to have a beneficial effect in weight reduction, and therefore the first trial came in 2021, once weekly semaglutide in adults with overweight or obesity. So these were step 1 and step 2 trial. In step 1 trial, the drug was used in patients who did not have diabetes, purely for management of overweight or obesity. And in step 2, the drug was used in patients of diabetes with obesity. And if you look at, it was a remarkable 16% reduction in weight at the end of almost 5 years. At the end of 5 years, and there was 18% reduction in weight as far as weekly follow-up was concerned. So roughly 16 to 80% weight reduction was seen at the end of 5 years in non-diabetic patients when they were put on semaglutide. Now, these are non-diabetic. If you look at step 2 trial, in which semaglutide was tried in patients of diabetes and obesity, there was almost 11% weight loss at the end of 6 years, showing that the drug has a robust reduction, in weight. So, step 1 trial concluded that among adults with overweight or obesity without diabetes, there was a 15% weight reduction when patients were put on semaglutide, and almost 87% of patients at least achieved 5% weight loss. 2 trial, in which it was used in diabetics, clearly showed that weight reductions was of at least 5% was achieved in 69% of patients, and there was roughly meaningful weight loss of more than 6.2% in patients of diabetes with obesity. This established the role of semaglutide in management of obesity with or without diabetes. The drug was available in oral form as 3 milligram, 7 milligram, and 14 milligram. And we have been using this drug up to 14 milligram in large number of patients of diabetes and obesity in India. Now, one step, the trials went one step ahead, in which a high dose of this drug was used and 25 milligram of drug was used rather than 3, 7, and 14. And in some trial, 50 milligram, a very higher dose of drug was used in management of obesity. And what did it show? That there was a huge weight loss to the tune of almost 9 kilo when the drug was used in a high dose of 25 milligram per day. If you look at the trial clearly showed that higher dose of semaglutide given once a day orally provided more effective glycemic control because it is basically an anti-hypoglycemic agent and a greater body weight loss than 14 milligram, the standard available dose. And therefore, this trial clearly proved that if you go ahead and push boundary and give higher dose of semaglutide to the tune of 25 and 50 milligram, there is going to be higher weight loss besides a good control of diabetes, showing that the drug has a robust role to play in management of diabetes. So Oasis 1 trial, when 50 milligram of oral semaglutide was given, again showed that the weight loss was to the tune of 15 to 17%, and almost 85% of patients had more than 5% weight loss, and 34% of patients. So 1/3 patient had weight loss about 20%. This was unbelievable goal before now semaglutide. And therefore, if you look at adverse events, the adverse events were there. There were GIT side effects like nausea, dyspepsia, distension, etc. But that was not so significant and would not prevent the onset of weight loss. So the trial clearly said that oral semaglutide 50 milligram led to a mean body weight reduction of 15% compared to 2.4% in placebo, and greater percentage of patients reached a body weight reduction of 5%, 10%, 15, and 20%. And therefore, the recommendation is that if you want to achieve a higher weight loss, semaglutide 50 milligram is a safe drug, is an effective drug, and could be a future option for patients with obesity. Now, what are the contraindications of this group of drugs? Obviously, there are adverse reactions like dyspepsia, nausea, indigestion, and so on, sometimes diarrhea. But the staging of the drug, starting from 3 milligram, going to 7 milligram to 14 milligram, and so on, reduces these side effects. The drug is completely contraindicated when there is a possibility of medullary thyroid carcinoma or a history of medullary thyroid carcinoma or multiple endocrine neoplasia, as well as in patients of thyroid tumors and pancreatitis. The second drug that was introduced is orforglipron, an oral GLP-1 agonist. The trial was published in September 23. This is different from semaglutide. This is an oral drug, and over a period of 36 weeks, there was a 14.7% change in weight loss, in weight, and absolute change in body weight was close to the 15% when this drug was given orally for 36 weeks, showing that there is a role of this drug. So 12 milligram or 4, or 24 milligram or 4, or 36 milligram or 4, or 45 milligram, there was close to 12.6% weight reduction with this drug compared to 2% with placebo, showing that this drug, oral drug, again, is a good drug to reduce weight in patients of diabetes. It is same GLP-1 analog. It is our oral tablet, is not yet available in India. So the trial clearly showed that daily oral Orfor was associated with weight reduction, and related benefits appeared to be similar to those observed with injectable GLP, that is semaglutide injection, and that have already been approved for weight management. This is a second drug that could be available to treat our patients with obesity and can be given orally. Then came startling new drug known as tirzepatide. This is a drug from Lilly. So the first drug, semaglutide, which changed the outcome, was was from Novo. The competitor Lilly came with a drug which is tirzepatide. It is a twin creatine, that means it works on both GIP-1 and GLP-1, and it is a agonist. Now, we've seen the effects of GLP-1 on pancreas, brain, stomach, and cardiovascular. This drug also works on GIP and increases adipose tissue blood flow, improves adipocyte metabolism, and therefore has an additional benefit besides having GLP-1 analog activity. So when this drug it decreases food intake, decreases appetite, increases weight loss, increases lipolysis, beta cell survival, improves cardioprotection, and decreases bone disruption. And therefore, tirzepatide, because of its effect on appetite, weight loss, lipolysis, is another drug which is a great drug in management of obesity. And the trial which was published, so these are the effects of drugs on GLP-1 and GIP, showing that there is a synergistic action as far as weight loss is concerned. The trial which was published in 2022 about tirzepatide, once weekly for treatment of obesity, SURMOUNT-1 trial, showed that there was almost 20% weight loss when 15 milligram of tirzepatide once a week was given to patients at the end of 72 weeks. So roughly at the end of 1.5 years, there was 20%. This was the first drug in history of medicine that gave roughly 20% of weight reduction. So all 3 doses of once a week tirzepatide, either 5 milligram, 10 milligram, 15 milligram, led to significant and meaningful weight reduction, but the first ever drug to reduce weight by almost 20%. And this again changed the outcome of obesity patients. This trial in large number of patients clearly showed that once a week tirzepatide showed, as we discussed, 20% weight reduction, and this drug then became Monjaro, became a drug to reckon with in management of obesity. A systemic review and meta-analysis of tirzepatide published in 2023 December for that large number of patients, close to 6,000 patients, showed that there was a remarkable weight reduction. And if you look at, there were some patients who achieved almost large number of patients, almost 1/3 of patients achieved more than 15% weight loss. So this drug has a significant potential as a weight loss drug in patients with overweight and obesity. The adverse effects are acceptable, and therefore, because it targets multiple metabolic GIP and GLP-1 enzymes, it should be considered as the next helm of weight loss therapy. And what happened if you look at comparison, semaglutide reduces weight by almost 14 to 50%, but when it is given in a high dose, as compared to the tirzepatide, reduces weight by 21%. Believe me, the drug Monjaro is now not easily available, and therefore the drug Lilly is not even interested in introducing it to Indian market because there is a huge international demand of this drug in management of obesity. Then you have third group of drug. These are triple receptor agonists. Retatrutide is a drug which works on both GLP-1, GIP-1, and glucagon receptor. Because of its action on GIP, GLP, and glucagon, the drug causes remarkable weight reduction. And if you look at the trial, the drug, because its additional action on glucagon, besides its action on GIP and besides its action on GLP, has a great role and excellent results in management of obesity. If you look at single agonist, a GLP-1, for example, semaglutide, it is an excellent drug for glycemic control. There is improvement in fatty liver, lipid profile, body weight. If you look at dual agonist, like tirzepatide, there is remarkable reduction in weight, and therefore, besides a good glycemic control. If you look at triple agonist, not only are they useful in controlling weight and sugar, but there is a remarkable improvement in fatty liver, and therefore these drugs will have a lot of role to play in management of patients of obesity with a significant fatty liver. If you look at trial of this drug, because of its effects on body weight, glycemia, reduction in weight, reduction in hepatic fat, the drug has a great role to play in management of obesity. And two trials, again published in Lancet and New England Journal of Medicine, clearly shown that when this drug was given, there was a remarkable reduction in weight, meaningful improvement in glycemic control, and the drug gave excellent result. If you look at body weight reduction, there was a close to 24% body weight reduction at the end of 48 weeks in some patients, showing that this drug again could be a game changer in management of obesity. So over 48 weeks, this was the first drug which reduced the weight by 24%, which could be as good as a bariatric surgery. So when retatrutide was given at a dose of 12 milligram, at the end of 48 weeks, some patients achieved weight loss of 24%. And the average weight loss in some patients was 26 kilogram at the end of 48 weeks, showing that this is a robust drug in management of obesity with least side effects. Then you have amylin analogs in management of weight. Cagrilintide is a drug which is an amylin analog. How does it work? It works on AMY receptor in CNS, improves satiety, reduces gastric emptying, and reduces food intake. And the drug has been tried for weight reduction as a solo drug, and the trial which was published in Lancet clearly showed that this drug at the dose of 0.3 to 4.5 milligram causes almost 10% of weight loss at the end of 26 weeks. The drug has a role to play in management of obesity. The weight loss was seen and comparable to drugs like liraglutide over a period of 26 weeks, but the drug alone may not be so useful, and therefore a combination therapy was given. So a drug in which both when the drug cagrilintide was combined with semaglutide. So this is sort of a combination therapy in which the drugs which work on glucagon, GLP-1, GIP, we saw them, the twin cretins and triple A receptor. Add to it amylin drugs, which reduces food intake, and then you could have a synergistic weight loss, which would obviate the need of bariatric surgery. So when cagrilintide was administered with semaglutide, so combination therapy, the trial which published in Lancet clearly showed that there was a remarkable weight loss at the end of 26 weeks. The weight loss was seen as high as 15% in large number of patients. And the study concluded that when you combine semaglutide and cagrilintide, there is a 15.6% weight loss at the end of 32 weeks. So showing that there is a hope and there is a ray of hope when you combine two drugs. Combined therapy shows a remarkable weight reduction to the tune of 16% and is to be given once a week and could be another option of treating patients of obesity. The trial, which was again published in Lancet, showed that combination of cagri and semaglutide resulted in significant weight loss compared to a solo therapy. The last group of drugs that we are coming to for treatment of obesity are inhibitors of the activin receptor signaling pathway, IASP. And bimagrumab is an antibody, and this is an era of antibodies, monoclonal antibodies. And this is a drug which blocks activin type 2 receptors, stimulates skeletal muscle growth. And therefore, there is an improvement of muscles and reduction in fatty mass. And this is how the drug works. I'm not going to go into details, but if you look at the trial which was published in JAMA Open, the drug, when it was given to 75%, small number of patients, there was a remarkable decrease in total body fat mass, reduction in A1C, increase in lean mass, and showed a remarkable improvement in weight reduction. So this drug, when it was compared with placebo, at the end of 48 weeks, there was remarkable improvement, 21% reduction in body fat and reduction in weight, showing that the drug has a role to play in management of obesity. So after that, you have a lot of newer drugs coming in management of obesity, like leptin analog, leptin sensitizer, drugs like adenovirus vaccine. Then there are the target drugs targeting CNS, drugs targeting gut hormones, and so on. And therefore, we have a bright future for management of obesity in years to come. So these are some likely drugs which will come in management of diabetes. Now, if you come to management with drugs or protocols that we want to follow in patients of the past obesity medications, the degree of body weight was close to 5%, were not safe. There were high incidences of depression, CNS side effects, did not demonstrate a CV benefit. So they just reduced weight. There were no CV benefits and did not demonstrate mortality benefits. So drugs like orlistat or drug like locazepine were just weight reducing drugs. Compared to that, the second generation drugs reduce weight to a large extent to the tune of 5 to 20%, have proven cardiovascular benefits, improve the outcome as far as malignancies is concerned, and have proven mortality benefits. Besides reducing weight, they also improve the liver functioning, and therefore are going to be good drugs to be available for treatment of obesity. So if you look at monotherapy, you have drugs like semaglutide, liraglutide, oral monotherapy like semaglutide, you have dual combinations like tirzepatide, dapiglutide, and you have dual combinations like cagri-sema, which are now available in management of obesity. And then you are going to have triple drug as we saw retatrutide. So you have a monotherapy, dual combination, and triple drugs available for management of obesity, and this is going to change the scenario of obesity. Various treatment algorithms which are given for obesity, depending on patient's metabolic profile, whether you should try to achieve weight loss early or whether you should go on a slow weight reduction, depending on comorbidity like diabetes, hepatic steatosis, cardiovascular problems, and so on. So these are various guidelines which are available for algorithms which are available for treating obesity, especially in Southeast Asia and in India. No, we can go into details later on, but suffice to say that when a patient comes to us initially, it is a lifestyle modification, the way, the diet, the exercise is going to be helpful. Calorie restriction has a major role to play. Again, we are not going to discuss diet. And then comes the role of pharmacotherapy, and then comes bariatric surgery, and so on. But at the same time, we ought to look for cardiovascular reduction, also look at hepatic improvement, and also look at reduction in other parameters like reduction in sleep apnea, reduction in arthritis, and reduction in cardiac arrhythmia. There are issues with obesity treatment. There is still no consensus as far as how much lifestyle modification is going to be helpful. What is the exact role of diet? Whether BMI should be the only criterion for labeling the patient as obese. Compliance of patient as far as lifestyle modification, diet, or BMI or exercise is concerned is still very, very poor. The drugs have side effects. They are very costly drugs. Nobody is certain of duration of therapy. Lot of authorities of who manage obesity clearly say that this could be a drug which you have to take lifelong, like you take aspirin, like you take statin, like you take antihypertensive, like you take diabetic drugs. These drugs may be required to be taken lifelong. Whether we should offer polytherapy and what should we do about comorbidities. So these are gray areas of obesity. Over a period of time, hopefully, we will have clearer vision. If you look at various options, dietary and lifestyle change in management of obesity, excellent results, but it is hard to follow. There is lack of motivation. Bariatric surgery, again, has issues, gives good weight loss, but then there are complications of surgery, weight regain, and costly. Anti-obesity drugs, which we discussed, reduce appetite, improve body weight, but there are side effects like nausea, GIT side effects, cost, and compliance. Then going to be nanomedicine is going to be one of the modalities of treatment of obesity in time to come. If I have to conclude, second generation anti-obesity medications have ushered in a new area in medical management of obesity. GLP-1 analog, semaglutide, 14 to 50 milligram per day, or the injectable once a week, and orforglipron offer 12 to 20% weight loss, which is a remarkable weight loss for any drug. Drugs like quinacrine, like tirzepatide, reduce weight loss by almost 20%, which is again a remarkable feat. Triple antagonist, a GLP-1, GIP-1, glucagon agonist like retatrutide will revolutionize the obesity therapy by giving us more than 26% weight reduction. Combination therapy, that is a combination of GLP-1 like semaglutide and amylin derivative like cagrilintide, is a promising option in management of obesity with a target weight loss of more than 16%. ISAP, bimagrumab, a monoclonal antibody, is a new approach to obesity medication with major emphasis on redistribution of fat. Drug therapy may obviate bariatric surgery, again, if and but, and not so clear. There are ifs and buts, and therefore, obesity, although is a very common disease, a strong willpower, compliance, guidance, and empathy from point of view of physician and family, and rigorous medication will help in management of obesity in time to come. And the disease, which was sort of a disease which was not giving good results and was considered as a poor treatment outcome in most of the patients, has now started showing good results with number of drugs. I thank you for your patience and for spending your valuable time. If there are any questions, I'll be pleased to answer.
Thank you, Dr. Rumin. An excellent overview of the newer modalities in management of obesity. Can you now switch on your video, Dr. Rumin?
It's just not working. I'm trying my best, but some camera problem. This has happened again. I don't know. I've trying. I can go with some other device at all. Yeah.
No.
Yeah.
To start with, my question is, you and other physicians who are in the audience, I mean, how far you have been using semaglutide, and what are your personal experiences, and how is the acceptance in terms of cost and side effects?
So semaglutide we have been using very frequently. It has given excellent results. The cost is a barrier because one tablet would cost around 370 rupees. Patients who are non-diabetic, diabetics, we use this drug mainly for treatment of diabetes, but those and obesity. But those who even who are non-diabetic, we have been using this drug frequently for management of obesity. Excellent results. Patients have lost up to 10 to 15 kilogram weight over a period of 6 months to 1 year. The compliance is good. The initial phase is a little dicey phase because when you go from 3 milligram dose, which is sort of a very, very mild dose, just a priming dose, when you go from 3 to 7 milligram or 14 milligram, the side effects start coming up. The nausea, dyspepsia, fullness of abdomen, diarrhea, and so on. If the patient is happy or is able to pass through that phase of about 1 month or so, 14 milligram, then there is a smooth outcome and the weight reduction is remarkable. The available option right now is only semaglutide to us. Tirzepatide is not available, and the cost which is available in Bombay in sort of off record, and the cost is around 1,20,000 rupees per injection.
So do you go beyond 14 milligram? In one of your slides, you had mentioned up to, I think.
We have so far not gone 14 milligram because it has not yet been approved officially. Trials have shown 25 milligram and 50 milligram as a useful adjunct.
Right. So now we are open to questions from the audience and comments. There are physicians. Yes, Jagdish.
Cost is main problem with semaglutide.
Absolutely. Cost is a major problem.
Yes.
Completely agree. Completely
Yes.
agree. Major problem.
And this drug has been in US market for more than 2 years. So a lot of our people, they have been on this drug for a long time. And they find it very good for control of diabetes and obesity both.
So most of the oral tablet that is available in Indian market is somehow does not go to Indian patients. They are all bought by NRI patients and
Yes.
large quantity, and that makes even the Indian price is cheap for them, and they can buy it for a year or so and give good results. But there are some patients in India who have been able to afford it and this drug has given good results.
Excellent presentation. We did not know so many anti-obesity drugs are available.
Thank you.
Excellent.
Thank you. Thank you so much. Thank you.
Any other question or comment? Okay. So thank you once again, Dr. Rumin, for an excellent, very informative talk. And we expect many more such talks from you in future again. So
Yeah,
thank you
Thank you so much.
for being
Thank you.
with us. Thank you all. We
Thank you.
meet next Saturday morning again. Thank you all.
Thank
We
you.
end the
Thank you.
session.
Thank you.